Imagine for a second that you are sitting in a perfectly quiet room. Like maybe you're at your desk at work, or picture yourself as a kid sitting in a dead silent classroom, right in the middle of a high-stakes math test.
Oh, literally the worst time for a distraction.
Right. It's the worst. And suddenly you feel this overwhelming, intense tickle in the back of your nose.
A sneeze is coming.
Exactly. A sneeze is coming. But you try to hold it back because, well, you don't want to disrupt the room. You know everyone will look at you.
Oh yeah, the social pressure is huge.
It is. So your eyes start watering, your chest physically aches, your heart rate actually spikes because you are fighting a biological reflex. You hold it and you hold it, but eventually, your brain overrides your willpower.
The body always wins.
It always wins. You sneeze, and then the teacher walks over, writes you up for being a disruption, and sends you to detention.
Which is completely irrational. You are being penalized for a physiological event that your nervous system executed without your permission.
Exactly.
But for millions of children, that exact scenario, being punished for an involuntary biological action, is not a thought experiment. It is literally their Tuesday afternoon.
Welcome to today's deep dive. We are exploring an incredible stack of clinical research and support documentation focused entirely on pediatric cyanic disorders.
It's such an important topic.
It really is. And through that lens, we are going to look at a genuinely groundbreaking K-12 mental health program in Georgia called MentalSpace School.
Yeah, their work is fascinating.
So the mission for us today, for you listening, is to tear down the damaging misconceptions surrounding invalidic disorders, understand the actual neurobiology of what is happening inside the brain, and look at how innovative school-based support models are completely revolutionizing student care.
Because the gap between what medical science understands about the neurology of tics and how the education system handles them is a massive chasm.
It's huge.
Bridging that gap is probably one of the most urgent conversations happening in pediatric mental health right now.
Okay, let's unpack this. Because the core misunderstanding we see running through all the clinical data is that, historically, schools treat tics as behavioral problems.
Right.
A kid jerks their shoulder or clears their throat repetitively, and it's just written off as a disruption. The adult in the room assumes the child is trying to get attention or, they're just being defiant.
They think it's intentional.
Exactly. So the kid is disciplined. They are told to just stop.
What's fascinating here is that when a school mismanages a tic by disciplining the student, they are basically throwing gasoline on a fire.
Oh, wow.
Yeah, because the child attempts to suppress the tic through pure willpower. They're terrified of the teacher glaring at them, or they're afraid of losing their recess.
Right, the stakes are high for a kid.
Exactly. And that intense suppression causes a massive spike in cortisol and adrenaline. Their anxiety just skyrockets. And neurologically, stress and anxiety are the absolute primary triggers that increase misstatic frequency and severity.
So the threat of punishment directly fuels the exact symptom the teacher is trying to stop. It's a closed loop of anxiety.
It's a devastating feedback loop. The student learns very quickly that their natural neurological state is unacceptable in that environment.
That's heartbreaking.
It is. And that realization leads directly to school avoidance, severe depressive episodes, and profound social isolation. The discipline doesn't cure the tic, it just breaks the child.
Man. To really understand why demanding a kid just stop is so absurd, we first have to establish what is physically happening in their body.
Right, the clinical definition.
Yeah. Clinically, NELST are defined as sudden, repetitive, non-rhythmic motor movements or vocalizations.
So on the motor side, you are looking at eye blinking, head jerking, maybe shoulder shrugging, or facial grimacing.
And on the vocal side, it's throat clearing, sniffing, grunting, or maybe even repeating syllables. But the absolute bedrock fact here is they are not a choice.
They are completely involuntary, and they are far more common than most people realize.
How common are we talking?
Roughly 1 in 160 school-age children meet the diagnostic criteria for Tourette syndrome alone.
Wow, 1 in 160.
Yeah, and that doesn't even account for the massive number of kids who experience transient or chronic occurrent disorders. We're talking about a very significant cross-section of your local school district.
So if tics aren't a choice, what is actually triggering the body to execute that movement?
Yeah.
The clinical data describes this biological warning sign that happens right before the tic. It's called the premonitory urge.
Right, the urge.
It's described as a physical sensation that builds up in the body, and is only relieved by actually performing the tic. It's like someone telling you to hold your breath indefinitely while you have the hiccups.
That's a great way to put it.
The physical pressure just builds and builds inside your chest until your diaphragm forces the action. And punishing someone for the hiccup just makes them panic.
Exactly. And if we look at the neurobiology behind that urge, it takes the blame entirely off the child's character. Deep in the brain, you have a structure called the basal ganglia. You can think of it as the brain's gatekeeper for movement. Normally, if you want to pick up a pencil, your cortex sends a signal, the basal ganglia opens the gate, and your hand moves.
Makes sense.
But in a brain with a Hillreck disorder, that gate is leaky. Random movement signals just slip right through.
So the premonitory urge is basically the conscious brain feeling that leaky signal building up against the gate.
Exactly. The sensory cortex registers this deeply uncomfortable physical pressure.
Wow.
Patients describe it as almost painful if they try to suppress it for too long. When the child finally releases that cortex, it is not an act of rebellion. It is immense physical relief.
Right.
When educators don't grasp that basal ganglia mechanism, they mistake a neurological pressure release valve for a behavioral middle finger.
Which brings us to the actual diagnosis, because Tourette's gets thrown around as a generic catch-all term in pop culture, but clinically the DSM-5 draws some very hard lines.
Very specific criteria, yeah.
Actually, wait, I need to stop you there and admit some confusion on this part of the source material. The diagnostic criteria require a child to have both multiple motor tics, A and D, at least one vocal tic, and they have to be present for over a year.
Right.
Why 1 year? And why the strict separation between motor and vocal?
Well, the 1-year mark is crucial because children's brains are rapidly developing and the basal ganglia goes through intense rewiring.
Oh.
A huge percentage of children will develop a motor tic-like hard blinking for a month or two, and then it completely vanishes forever. Those are called transient tics.
Got it.
The DSM-5 requires the 1-year duration to filter out typical developmental hiccups from chronic, enduring neurological conditions.
Okay, that makes sense. So if it's under a year, it's just provisional tic disorder.
Exactly. And regarding the motor versus vocal separation, if a child only has motor tics or only has vocal tics for over a year, that is classified as persistent or chronic tic disorder.
So what pushes it to Tourette's?
To meet the threshold for Tourette syndrome, the neurodevelopmental profile has to be complex enough to manifest both motor and vocal tics.
I see.
And a key feature of all these diagnoses is that they wax and wane. The tics change in frequency, they change in intensity, and they even change form. A blinking tic might vanish, only to be replaced by a shoulder shrug 3 months later.
You can see how that naturally fuels a teacher's skepticism, though. Like, well, he wasn't shrugging his shoulders yesterday, so he must be making it up today to get out of reading out loud.
Right. It demands an incredible amount of patience and understanding from the adults, especially considering that tics typically peak in severity around ages 10 to 12.
Middle school.
Exactly. Think about what is already happening at age 11, the social dynamics, puberty, the middle school transition. It is an incredibly turbulent time to suddenly lose control of your own body in front of your peers.
That sounds like a nightmare.
It is. The silver lining is that the severity frequently decreases by late adolescence or early adulthood as the brain matures.
But looking at the clinical data, there is a reality here that completely changes the narrative. The comorbidities.
Yes, the hidden conditions.
The hidden conditions that ride alongside the tics. The data shows that ADHD is present in roughly 50% of kids with Tourette's, half.
It's a massive overlap.
And OCD is present in 30 to 50%. Plus, they have disproportionately high rates of anxiety, mood disorders, and specific learning differences.
This is the critical piece of the puzzle that almost always gets missed in the classroom.
But realistically, if I'm a teacher and a kid is grunting in the middle of a math test, that is the immediate problem in front of me.
Sure.
So I'm pushing back here. So what does this all mean? If ADHD and OCD are frequently causing more functional impairment than the tics themselves, are schools and parents entirely missing the plot by hyperfixating on the tics just because they are the loudest symptom?
This raises an important question, and yes, they often are. Clinicians refer to this as the iceberg effect.
The iceberg effect.
Right. The tics are the tip of the iceberg. They are visible, they are audible, they are above the waterline, they demand immediate attention.
Okay.
But the massive hidden block of ice beneath the surface, the crippling executive dysfunction of the ADHD, the paralyzing intrusive thoughts of the OCD, the overwhelming social anxiety, that is what is actually sinking the ship.
So the kid clears their throat, and the teacher focuses entirely on the throat clearing,
And go.
completely unaware that the kid is internally obsessing over the fact that if they don't tap their pencil exactly 4 times, their OCD is telling them their parents are going to get into a car crash.
Exactly. The clinical reality is that the comorbidities frequently cause far more functional impairment to the child's life and learning than the tics themselves.
Wow.
If you only treat the tic, or worse, is just punish the tic, you are just chipping away at the tip of the iceberg while the kid drowns. But if you treat the underlying anxiety or manage the ADHD effectively, you improve the child's overall neurological stability.
Which helps the tics.
Exactly. That reduces their systemic stress, which naturally reduces the frequency of the tics. Everything is deeply connected.
Okay, so if discipline is actively harmful, and we know the condition is deeply intertwined with the iceberg beneath the surface, how do we actually intervene?
We need real tools.
Right, because we can't just abandon all structure.
Yeah.
The clinical guidelines point to a very specific evidence-based treatment called CBIT. That's CBIT, which stands for Comprehensive Behavioral Intervention for Tics.
Yes.
How does this actually work in practice?
Well, CBIT is a fascinating behavioral therapy because it doesn't rely on willpower or suppression. The first core component is awareness training.
Awareness.
Right. Because tics become so habitual, many kids, especially younger ones, might not even realize they're about to execute a tic until the movement is already over.
Oh, interesting.
The therapist works meticulously with the child to help them isolate and identify that premonitory urge. They learn to feel that exact physical warning sign in their body.
Here's where it gets really interesting to me. Once they have that awareness, they move to competing response training.
Yes.
Think about defensive driving. If you're driving down the highway and a hazard suddenly appears in the road, that hazard is the premonitory urge. You can't stop the hazard, the urge, from appearing on the road.
Right. You can't control it.
Exactly.
Yeah.
And if you don't know what to do, you panic, you jerk the wheel, you crash. That's the uncontrolled tech.
The crash.
But with defensive driving, you have trained your muscle memory so that the second you spot the hazard, you execute a very specific, calculated, safe maneuver. You don't eliminate the hazard, but you safely navigate it rather than just bracing for the impact.
That's a perfect analogy. And neurologically, that is exactly what competing response training does. The therapist and the patient develop a voluntary movement that is physically incompatible with the tic.
How does that look physically?
Let's say the tic is a severe, forceful head jerk backward. The competing response might be to gently and voluntarily tense the neck muscles to pull the chin slightly down toward the chest.
Oh, I see.
The moment the child feels the urge, the hazard on the road, they execute the safe maneuver. They hold that subtle, socially unnoticeable posture until the neurological urge passes.
It gives them the steering wheel back.
That gives them total agency. I mean, before CBIT, these kids feel like passengers in a body they cannot control. They feel victimized by their own nervous system.
Yeah, totally helpless.
CBIT shifts them from being passive victims to active participants in their management. It actually rewires the habit loop in the brain, training the basal ganglia that the urge does not have to result in the tic.
And the protocol goes beyond just the physical response, right? It includes functional intervention, which means analyzing the child's environment.
Absolutely.
Like, are they ticking more in math class because they have an undiagnosed math learning disability causing stress? You fix the math support, you lower the stress, you reduce the add in relaxation training and family education, and it's an incredibly holistic approach.
It is, but it's important to note that behavioral therapy isn't the only tool. For moderate to severe cases where the tics are physically painful or severely interfering with the child's daily functioning, there are medical interventions.
Like medications?
Yes. Licensed medical clinicians might prescribe medications like alpha agonists, drugs like clonidine or guanfacine.
I always thought those were blood pressure medications.
They are originally, but they work by acting on receptors in the brain to lower sympathetic nervous system arousal.
Okay.
Basically, they turn down the body's fight or flight response. Less adrenaline flowing through the system means less hyperexcitability in the basal ganglia, which often translates to fewer tics.
That's sad.
In some highly specific treatment-resistant cases, atypical antipsychotics might be used to block dopamine receptors since dopamine fuels movement. But the key takeaway from the clinical consensus is that medication is almost always most effective when used in tandem with CBIT and when directly addressing those underlying comorbidities like ADHD.
Okay, so we have the science. we have highly effective clinical tools. CBIT works, the medications work.
Yes.
But here is the massive logistical collision. A kid might spend 1 hour a week in a pristine, quiet clinic learning these techniques, but they spend 35 hours a week in a chaotic, loud, highly demanding classroom.
The classroom is the real test.
The classroom is the crucible. That is where the social stakes are highest. What are schools actually supposed to do to bridge this gap between the clinic and the classroom?
The clinical guidelines lay out clear directives for schools. First, absolute baseline, educate the staff. Teachers must understand the neurobiology we just discussed.
Essential.
Second, implement environmental accommodations. If a child has a severe arm-jerking tic that interferes with handwriting, give them extra time on tests or let them type. Give them a permanent hall pass.
Oh, hall pass is smart.
Yeah, seat them near the door so if a massive wave of tic storm comes on, they can quietly step out into the hallway without feeling like they're putting on a spectacle for the entire room.
And the research heavily emphasizes educating peers, with the family's permission, of course. Bullying drops off a cliff when classmates actually understand what is happening.
It really does.
Kids fear what they don't understand. But if a teacher explains, like, hey, his brain just sends a signal that makes him clear his throat, it suddenly stops being weird. It just becomes a fact about their friend.
Knowledge creates empathy. But practically speaking, managing all of this, coordinating the accommodations, handling the comorbidities, managing the emotional fallout is incredibly difficult for an overstretched school system to do internally.
Right. Delivering specialized care directly into a school environment sounds like a logistical dream. But my immediate thought is, does this actually work, or is this just a cheap way for schools to outsource their problems? How do you get high-level clinical support into a public school building?
It's a huge challenge.
Which brings us to MentalSpace School in Georgia. They are running a K-12 mental health support model that completely flips the script on how schools handle complex neurological profiles.
Their approach tackles the exact logistical bottlenecks that usually cause these kids to fall through the cracks.
Let's look at the actual mechanics of MentalSpace School, because they don't just send a traveling counselor around the district. They provide same-day teletherapy directly to the students at the school.
Same day is crucial.
Yeah, and they assign dedicated, consistent therapist teams to specific schools. And the critical detail here is that these therapists aren't just general practitioners. They are specifically trained in CBIT and in treating those massive underlying comorbidities, the ADHD, the OCD, the clinical anxiety.
That specialization is the entire ballgame. I mean, you cannot just throw generic cognitive behavioral therapy at Tourette's or severe OCD and expect a reduction in symptoms.
Right.
You need clinicians who understand the basal ganglia, who understand the premonitory urge, and who can execute competing response training. By delivering that specialized care via teletherapy directly to the school on the same day a child might be in crisis, you are intercepting the anxiety loop before it spirals into school refusal.
But the immediate skeptical question any parent or school administrator is going to ask is about the cost. Specialized neurological care is notoriously expensive.
It is.
But MentalSpace School operates at $0 cost for families on Medicaid. Zero. And they accept major plans. They're fully in network with BCBS, Cigna, Aetna, UHC. It's fully CIPA and FERPA compliant.
That accessibility is incredible.
And for districts in Georgia, it specifically supports them in meeting the upcoming HB 268 compliance deadline hitting in July 2026.
By removing the financial barrier, eliminating the transportation barrier of parents having to leave work to drive to a clinic, and completely bypassing the typical 6-month wait list for pediatric specialists, they are catching these kids in real time.
The data coming out of the MentalSpace model is hard to argue with. They are reporting an 89% improvement in student attendance, a 92% reduction in clinical anxiety, and an 85% family satisfaction rate.
Those numbers are massive.
When we look at those success rates, 89% improved attendance for kids who are likely terrified to walk into a building, it begs the question, is the traditional school discipline model fundamentally broken for neurodivergent kids? And is this integrated teletherapy model the only way to actually fix it?
If we connect this to the bigger picture, the answer is unequivocally yes. The traditional disciplinary model, the detention, the suspensions, the behavioral charts, was engineered entirely for neurotypical behavior.
Right.
It relies on the assumption that all disruption is a conscious choice. When you apply that assumption to a neurodivergent nervous system, it isn't just ineffective, it causes active psychological harm.
Yeah, we talked about that cycle of stress.
Exactly. What MentalSpace School represents is a vital paradigm shift. It forces the entire educational ecosystem, educators and parents, to stop asking, how do we make them stop? And finally start asking, how do we support them?
How do we support them? That one shift in language changes the entire trajectory of a child's life. Instead of being the problem kid banished to the principal's office, they are a student managing a neurological condition, and when they have a flare-up, they open a laptop and immediately connect with a specialized clinical team that has their back.
It's revolutionary.
If you want to see the exact mechanics of how they are doing this in Georgia, you can check them out at mentalspaceschool.com.
It is a model of care that honors the complexity of the whole child, rather than just policing their visible symptoms.
So as we wrap up this deep dive, I want to bring this directly back to you, the listener. Think about how you react when you feel a sudden wave of panic or an uncontrollable itch. Now imagine trying to hide that from the world under threat of punishment.
It's exhausting to even think about.
The takeaways here are profound. Tics are neurobiological urges, not behavioral choices. The hidden comorbidities beneath the surface, the ADHD, the OCD, are almost always causing the child far more suffering than the tics themselves. And when we replace punitive discipline with hyper-accessible, comprehensive support like the MentalSpace model, we don't just improve test scores. We give these kids their lives back.
And this matters for everyone, not just parents or educators navigating menardic disorders. Understanding the fundamental biological difference between a chosen behavior and an involuntary neurological response completely changes the lens through which you view society.
Empathy over annoyance.
Exactly. When you see someone doing something repetitive or seemingly disruptive in public, your immediate instinct shifts away from judgment and annoyance and moves toward curiosity and empathy.
It forces us to give people grace. It makes us better humans.
It absolutely does. And it leaves us with an incredibly compelling question for the future of education. If a program like MentalSpace can use integrated telehealth and highly specialized clinical interventions to completely restructure how a school handles a complex condition like Tourette's achieving a 92% reduction in anxiety, could this exact neuro-affirming, hyper-integrated model eventually replace standard disciplinary systems for all behavioral challenges in education?
Could we finally move past the dark ages of punishing the symptom? Think back to that kid we talked about at the very beginning, sitting in that silent classroom. The physiological pressure is building. The urge is screaming in their brain. But this time, instead of a glare and a detention slip, the teacher gives them a subtle nod. They step out. They log on with a clinical specialist who understands exactly what their basal ganglia is doing. No panic, no punishment, just immediate specialized support. That is a classroom worth building.